Why does the shoulder dislocate so easily, even though it has maximum mobility? The answer is hidden in today's lecture, and 90% students get it wrong. This is part 2 of our shoulder biomechanics series, and today we are going deeper in the concepts that are directly asked in MUHS exams and CET MCQs. If you haven't watched part 1, go watch that first because today we are building on that foundation. By the end of this lecture, you will be able to understand the concept clarity, apply it in MCQs, and most importantly, use it clinically. And also, I'll show you one shortcut that will help you solve your MCQs instantly. Now let's quickly go through the joints that is we discussed in the last lecture, the four important joints which form the shoulder complex, that is the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, and one joint that is scapulothoracic joint, which is not a true structural joint but serves as a functional important joint. Let's go to sternoclavicular joint. For entire joint mechanics and the bones and the articulations involved, please refer to the last lecture. Now, the sternoclavicular joint is called as the axial anchor. Why so? Because it is the only joint which serves as the bony attachment of the upper limb to the axial skeleton. So here as we see the sternoclavicular joint, this serves as the attachment of the entire appendicular skeleton with the axial skeleton. So this sternum, manubrium sternum forms the axial skeleton and the entire limbs form the appendicular skeleton. This allows the motions of retraction and protraction. So the motions include retraction, protraction, elevation, depression, and rotation, which happens when you do flexion of movement or even you do internal and external rotations. This anchors the entire shoulder complex. Now let's move on to the acromioclavicular joint, which is formed here by the lateral end of the clavicle and the acromion process of the scapula. So this acromioclavicular joint links the acromion of the scapula to the lateral end of clavicle. It provides subtle movements including internal external rotation. So consider this as clavicle and this as the scapula, this being the acromion process. So now the movements available here include internal and external rotation, upward and downward rotation, and anterior or posterior tilting. These are very essential for fine tuning of scapular position and enabling overhead movements. So we will come to glenohumeral joint mobility and scapulohumeral rhythm where we will discuss this in detail. Moving on to the next joint, that is glenohumeral joint. This is called as the mobility king because it is a ball and socket kind of joint which has maximum joint mobility. Okay. Now the ball and socket joint between the humeral head and the glenoid fossa of the scapula. As we see here, humeral head and the glenoid fossa of scapula. This offers the greatest range of motion in the human body, allowing for flexion, extension, abduction and adduction, and internal rotation and external rotation. I am not demonstrating these movements because we are very well versed with these movements. And this joint sacrifices stability for extreme mobility. Moving on to our functional scapulothoracic joint. This is called as the functional slider as we rightly know because this is not a structural attachment but is attached, that is scapula is attached to the thorax via the muscles. It is not a true anatomical joint but is a functional interface. It relies on muscles for movement and stability, allowing for extensive protraction and again, so protraction and retraction movement, elevation and depression movement, and upward and downward rotation. This acts as a dynamic base for entire arm movement. Now, since today we are going to discuss about the kinematics, that is osteo and the arthrokinematics in this lecture, what important thing which we should know is concave-convex rule. If you are not thorough or have any doubts in concave-convex rule, please see the video on concave convex rule, and I'm sure it will help you. So, beginning with this, to maintain joint integrity and prevent dislocation, the articular surface must roll and slide as we had discussed. If there is no proper arthrokinematics, that is inside the joint, that is articular movements, then there are chances of either dislocation or impingement. Moving on to concave convex rule, just remember the tire. If you see in this image, there is this tire which is sliding backwards, that is sliding in this direction and rolling forwards. Okay, so this is the one surface and this is another surface. Let's consider this is glenoid fossa, this is head of humerus. Now concave moving on convex, roll and slide occur in exactly, they occur in the same direction. Now if convex is moving on concave, recollect it. Yes. So the convex moves on concave, roll and slide occur in the opposite direction. So this is all about concave and convex rule. To the sternoclavicular joint, why is it called as the axial anchor? Because of the structure. So the sternoclavicular joint is formed by the medial end of the clavicle and the manubrium sterni. The surface of the clavicle is actually not plane, it has curvatures, because of which it is called as the saddle shaped plane synovial joint, the only structural attachment of entire appendicular skeleton with the axial skeleton. Now the pivot point, the most important attachment of the fibrocartilaginous disc, which is attached diagonally. So this is the clavicle, this is the sternum, the disc is attached diagonally. The most important thing, very important for your CET, is to remember the attachment, because this answers whether the disc will be the part of the clavicle or the part of the manubrium during the movements. So remember, it moves with the manubrium during elevation and depression, and it forms the part of the clavicle, that is the entire disc, and the clavicle moves on the sternum during protraction and retraction. So I used to remember it like this. Check if this helps you. So I used to remember the word C, then P, and the letter R. So CPR, we usually refer this in our exams, or CPR is the BLS important thing. So C stands for clavicle. Okay. P stands for protraction and R stands for retraction. So disc is the part of clavicle during protraction and retraction. Now we'll be discussing about the osteokinematics and arthrokinematics of all the joints individually in detail. Osteokinematics involve the movement of the bony levers and arthrokinematics involve movements happening at the joint. The movements include elevation and depression. So do it by yourself. When you do elevation and depression, the movements happen in the frontal plane across an anterior-posterior axis. The range of motion is elevation up to 48 degrees and depression is only less than 15 degrees. Arthrokinematic movements involve convex moving on concave. Please remember here, due to the subtle articular surface of the clavicle and the manubrium sterni, here the concave and convex rule is not same for all the movements. So when we talk about protraction and retraction, here the convex is going to move on concave. So here the roll and glide will happen in the opposite direction. So for elevation, the roll would be superior and the glide would be inferior. Whereas similarly in depression, the roll will be in inferior direction and slide would be in superior direction. Moving on to protraction, retraction, this movement happens. So it's a protraction and retraction. It happens along the vertical axis. Protraction range of motion is 15 to 20 degrees and retraction around 20 to 30 degrees. Here there is a reversal of the concave convex rule due to the subtle articular surfaces. Here the concave moves on convex. So now the roll and slide will happen in the same direction. So for protraction, anterior roll and slide, and retraction, posterior roll and slide. Rotation happens along the long axis, that is longitudinal axis. Posterior rotation up to 50 degrees and anterior rotation is less than 10 degrees, that is coming back to its original position. The spin, so actually clavicle spins posteriorly. So the clavicle spins posteriorly and inferior surface faces anteriorly. We'll discuss this when we discuss the glenohumeral joint movement. But always remember, when you do movements like this, you will feel the medial end of the clavicle going upwards and posteriorly. So this is exactly the joint kinematics of sternoclavicular joint. Now always remember this for your exams, and examiners actually love this because the concave-convex rule reverses for the moments separately. So because the elevation uses convex on concave while protraction uses concave on convex. This is very important. Examiners love this question for their viva traps, for your MCQs. This has been asked in CET and is really important for your clinical practice as well. The AC joint, it's also called as a scapular fine tuner. We'll understand why. This is because of its structure. It is a plain synovial joint formed by the lateral end of clavicle and the acromion process with variable incongruent facets and has various lipids and fibroarticular components inside this joint. The primary function is it lets the scapula rotate and tip to stay flush against the curved rib cage. So now the scapula is here on the thoracic cage. The entire movements of the scapula, which we discussed, of elevation, depression, protraction, retraction, all these movements happen at the clavicle and the acromion junction, that is acromioclavicular joint. The axis motions occur around the axis oriented to the plane of the scapula, that is scaption plane, and not according to the cardinal plane. So cardinal planes are frontal, sagittal and horizontal, whereas scaption, that is the position of scapula, is 10 degrees anterior to the vertical plane. It is 15 degrees upwardly rotated. So these are the changes, and that is formed as the scapular or scaption plane. Always remember for your exams, that is upward rotation at acromioclavicular joint. That is upward rotation is physically limited by tension in the coracoclavicular ligaments. Very important for your CET. Moving on to the acromioclavicular joint kinematics. So we'll include the movements of internal and external rotation. These movements happen across the vertical axis in the horizontal plane. The range of motion is 20 to 35 degrees and is maximum up to 60 degrees. The arthrokinematics, this maintains the scapular contact with the horizontal thorax curve. Now, anterior and posterior tipping of the acromion on the clavicle. This happens in an oblique coronal axis. Please remember this. The movement is 30 degrees and is maximum up to 40 degrees. The acromion tips forwards and backwards to follow the vertical rib curvature, okay, of the thoracic spine. Next is the upward and downward rotation. Again, this happens across the oblique anterior posterior axis up to 30 degrees, that is passive. Why we have used the term oblique here is these movements happen in the scaption plane, scapular plane, that is why. Now this tilts the glenoid fossa up and down and is limited by coracoclavicular ligaments. The importance of tilting of glenoid fossa up and down, we'll understand this when we discuss the glenohumeral joint mechanics. Always remember, and is a note for you, that is arthrokinematics, that is roll and slide are unpredictable here due to highly variable flat or reverse joint surfaces. So actually the acromion is more over a plane surface. Clavicle lateral end is almost a similar plane surface. So these are two actually similar plane surfaces which are connected via ligaments. And there are many adipose, fibrous tissue inside it. That is why the movements are little unpredictable at this joint. But this joint is highly susceptible for degeneration. So the arthrokinematics is very important to be known to us. Now comes the functional joint, that is scapulothoracic joint. It's the functional slider. The key concept is it's not a two anatomical joint. The scapulothoracic motion is a direct closed chain. Please remember the word, it is a direct closed chain result of the sternoclavicular and the acromioclavicular joints movement combined. So here you have the acromioclavicular movements and here you have the sternoclavicular movements. You cannot see it in the posterior view, but I'm sure you know it now. So the entire movement happening here is a closed chain between these two joints. Now the resting position, as we have already discussed in previous lectures, I'm not repeating it. Internally rotation, anteriorly tipped and upwardly rotated, that is, it comes into a scaption plane. And the primary movement here is upward rotation, which is around 60 degrees, which is available to elevate the arm. Remember for your exams that scapular winging is biomechanically defined as excessive internal rotation at the AC joint. So here you see this, the inferior angles of the scapula you see. So these are pointing outwards, that is abnormal. Okay, this is called as the winging of the scapula. So now these scapular winging is defined as the excessive internal rotation at the AC joint because the scapula is come like this. Okay, these are the inferior angles which have come out. So excessive internal rotation at the AC joint causing medial border to pop off the thorax. The contact of the scapula from the thorax comes off. Okay, it comes off like this. This is, and the muscle weakness, you have to comment actually the muscle weakness which causes the winging of scapula. Now, the final glenohumeral joint, which is the maximum mobility joint. Remember the structure, it is a ball and a socket joint with the humerus much larger than the glenoid fossa surface. Now, if there is pure rolling occurring or pure sliding happening, the humerus will roll out of the edge of the glenoid fossa. So here there is a large ball and a shallow socket. There is mandatory sliding actually happening. The humeral head must slide opposite to its role to stay centered in the joint. If it doesn't, it will dislocate. The joint kinematics of the glenohumeral joint. So the movements happen here include flexion and extension, which happen in a sagittal plane across the frontal axis, that is coronal axis. The range of motion is of 100 to 120 degrees and there is pure spin in sagittal plane and is accompanied by slide depending on the rotation and concave convex rule. Next comes the abduction and adduction. So concave convex rule for flexion and extension is that roll occurs superiorly and the slide occurs inferiorly. Now abduction and adduction, the movement happens in across the anterior posterior axis in the frontal plane. Abduction range of motion is 90 to 120 degrees. Abduction includes superior roll and inferior slide, and adduction involves the vice versa, that is inferior roll and superior slide of the head of humerus. Medial and lateral rotation, these movements happen across the longitudinal axis in the transverse plane. Lateral rotation is of around 43 degrees during abduction, that is this movement. Lateral rotation involves posterior roll. Now, always you do it by yourself, so you remember it well. And imagine the humerus moving in posterior direction, that is, roll is in the posterior direction and slide is anteriorly. Medial rotation, the roll is anterior and the slide is posterior. Once you remember the concave convex rule, I am very sure you can answer this well. Clinical application of why arthrokinematics matters. So let's take this case scenario. A patient comes to you and is presenting with pain during glenohumeral abduction, that is overhead reaching. There is something called as painful arc. We will discuss about this later. The biomechanics of the normal abduction according to concave convex rule, recollect, so the convex humeral head to slide inferiorly downwards while it rolls superiorly. So this is healthy mechanics. Now abnormal mechanics involves the humeral head getting impinged here. So this is the humerus head and this is the acromial surface, that is the arch. Okay. Now here the head of humerus is rolling upwards but there is no inferior slide. The inferior slide is absent, so there is going to be impingement up here. Now, if you have seen the previous lecture, you will be able to answer why does the inferior slide not happen and which set of muscles help the inferior slide. Always remember for your exam tip that inferior sliding is restricted. The humerus head simply rolls up the glenoid. This causes subacromial impingement. This is called a subacromial impingement, and there are contents of subacromial space. You have to recollect that from the previous lecture. This happens against the coracoacromial arch. Most important exam favorite question of your Viva and CET, and actually very important for your assessment and management, that is scapulohumeral rhythm. Now, to achieve a maximum of 120 degrees, 180 degrees of arm elevation, the joints must share the mechanical load. This mechanical load is shared among all the four joints. Important in the scapulohumeral rhythm to discuss include glenohumeral joint, which shares the 2 degree to 1 degree of scapulothoracic joint. So 120 degrees of glenohumeral joint motion when added with 60 degrees of scapulothoracic joint motion sums up to the 180 degrees of arm elevation. So there is 2 is to 1 ratio. Always remember 2 is for glenohumeral and 1 is for scapulothoracic. In that quick answer giving of MCQ of 1 second in CET, we tend to just, though we know the right answer, sometimes it happens that we click the wrong option. So always remember 2 is for glenohumeral and 1 is for scapulothoracic. This includes upward rotation of scapula, be it in flexion, which includes more rotation, that is internal and upward rotation, or pure abduction. Why this matters, remember the 4 pointers very well, that is, this facilitates the upward rotation of scapula and overhead activities. This distributes motion to preserve joint stability, and this keeps the glenoid facing the humeral head, also prevents the active insufficiency of the shoulder muscles. Remember this diagram, which will help you remember the 2 is to 1 ratio, that is 2 is for glenohumeral and 1 is for scapulothoracic joint. Now I came across this amazing video which explains scapulohumeral rhythm like nowhere else. So let's just look at this moment. Here the humerus moves and the scapula moves after some degrees. Right now the humerus moving, the scapula is static at its position in the initial ring. Now it started moving. Okay. So initial degrees of the overhead abduction is by only the glenohumeral joint, that is only 30 degrees is purely by glenohumeral joint. Post that, the scapula starts moving upwardly and provides 50 to 60 degrees of upward rotation. Now this entire 60 degrees of scapulothoracic joint plus 120 degrees of humeral abduction totals of 180 degrees of overhead abduction. So until the 30 degrees have crossed for abduction, the movement is purely by glenohumeral joint and the scapula doesn't move off the thorax. Again, see it very well. This is very nicely explained. Similarly, what happens in flexion is until 60 degrees of glenohumeral flexion, the scapula doesn't move. Only post that, the scapulothoracic joint movement contributes. So always remember this, that the scapula moves only after the pure certain degrees of motions of humeral abduction, that is 30 degrees, glenohumeral abduction of 30 degrees and glenohumeral flexion of 60 degrees is completed. If the scapula starts moving before that, we call it as altered scapulohumeral rhythm, and there are various reasons for it, which we shall discuss in the next upcoming videos. So these overhead activities are a chain reaction, that is chain reaction of the arm elevation. So this happens into 4 phases: phase 1, phase 2, 3 and 4. So phase 1 is glenohumeral and sternoclavicular joint contributing to the movement. So the humerus, that is glenohumeral joint, abducts the clavicle. You do it by yourself. So let's do it. The glenohumeral joint abducts, the clavicle elevates, that is the sternoclavicular joint is contributing during early scapular upward rotation. Then transiting to phase 2, now the sternoclavicular joint, glenohumeral joint contributed. Next comes the acromioclavicular joint. So the coracoclavicular ligament, we remember, this tightens as the scapula rises and tries to rotate further but is locked by the clavicle. So coracoclavicular joint tightens up as the scapula rotates upwards. Now comes the sternoclavicular rotation. So the clavicle rotates posteriorly, and this happens up to 50 degrees along its longitudinal axis. There is posterior rotation of the medial end, the entire clavicle. This creates slack in the tense ligaments, which helps the further range of motion availability. And the phase 4 ends at the acromioclavicular joint and the scapulothoracic joint. Now the acromioclavicular joint is freed due to the taking up of slack. This allows the final 30 degrees of scapular upward rotation, and this is required to reach a full of 180 degrees overhead movement. Just imagine if the clavicle doesn't rotate posteriorly. Will you be able to complete the entire range of motion? Absolutely no. So entire face and each joint contributing at the right time in the phase of abduction or flexion, that is overhead activities, is very important. So remember the memory hack. Clavicular posterior rotation is the secret switch that unlocks the full overhead reach. This is very important for your CET. Just note this down or maybe screenshot this slide. So the clavicular rotation, posterior rotation, is the switch to unlock the full overhead reach. And this happens post 90 degrees. Remember this. So 90 degrees of abduction or flexion, post that clavicular posterior rotation happens, and this allows the further range of motion. Now this is a quick revision. Just screenshot this slide, which will help you for your clinical decision making and getting your MCQs right. Let's go. Now first is the sternoclavicular joint. It is a saddle variety of plain synovial joint involving the key osteokinematic movements of elevation, depression, protraction, retraction, and axial rotation. The disc is in a diagonal way, that is pivot sternoclavicular disc. Elevation uses concave-convex rule and protraction retraction uses concave-convex rule, but is altered due to the subtle saddle surfaces. Remember CPR technique, clavicle is a part of the disc during protraction and retraction, and vice versa. Now coming to acromioclavicular joint is a plain synovial joint involving movements of internal external rotation, tipping up and down rotation. It tunes the scapula to the curved thorax, and the motion is limited by the coracoclavicular ligament. Very, very, very important. Next is the functional scapulothoracic joint, which provides upward rotation of 60 degrees and the max of the scapulohumeral rhythm, that is sternoclavicular joint and acromioclavicular joint combines together. The winging, that is excessive and acromioclavicular internal rotation, and weakness of the muscle. I had asked you before. The answer is serratus anterior muscle weakness causes winging of scapula. And next is the glenohumeral joint, which is the ball and socket variety of synovial joint involving movements of flexion extension, abduction adduction, and medial lateral rotation. Remember, it is a large ball and a small socket. Abduction absolutely requires inferior slide to prevent impingement. And I had asked you the question, who provides this inferior slide? The answer is rotator cuff muscles. I'm sure you answered it rightly. If you are someone who is preparing for MUHS exams or CET and you feel like you are studying but not retaining, you don't know what is actually important, or you confused with concepts like this, then I have created something specially for you. My mentorship program is there available, and it's not just lectures, it is a structured system where I guide you what to study, and how to score maximum marks in exam with minimum confusion. If you're serious about improving your scores, check the link in description or pinned comment. I have explained everything there. And before you go, ask yourself, can you explain this whole concept in quick 30 seconds? If not, rewatch this part 1 and you will thank yourself in exam. If this lecture made even one concept clear for you, make sure you like the video, comment done so I know you have completed, and subscribe because part 3 is coming, and that's where things get even more interesting. All the best. Thank you.